This is, I think, the final seminar for the fall, so glad you're here, and keep your eyes open for the plans for spring. And we'll start with Dr. Stephen Kelder, who's professor and Department of Epidemiology at UTHealth Houston, School of Public Health, Austin. Did I get that right? I think I got that right.
Yep.
And Stephen designs, implements, and evaluates behavioral interventions targeting young people, which is exciting. The focus is on seemingly all the things that we want to prevent in the lives of kids: tobacco, substance use, oral health promotions, traffic safety, obesity, promoting physical health and health behaviors. Super interesting. Co-founded the Catch Global Foundation that trains and disseminates health programs nationally and internationally. Super interested to learn about that too. But I'm going to turn it over to Dr. Kelder, and use the chat for questions or comments, or just, we're a small group, so we could either, whatever you think is the best ways. Steve, do you want to save questions to the end, or people can
I'm fine either way
as we go?
But I'm going to have to move through quickly enough to give Kavita her time too.
That's true.
So maybe we can save the questions till the end.
Sure.
And,
sounds good.
Anyway, let's get going. Thank you very much for that introduction. Can you guys see?
Yeah.
Good. Okay, I'm going to talk about a program called Catch, which I've spent a long time on. In fact, you see in the red there, I was at the University of Minnesota. I was getting my MPH when Catch started as pilot studies. So the history of working in schools with diet and physical activity comes from projects which were funded in the early 80s, late 70s, that were cardiovascular disease prevention oriented, knowing that movement, physical activity, and food were related to the risk factors, what we call the primordial risk factors for cardiovascular disease. And you can trace that down to occluded blood vessels that were discovered in the Korean War for kids about 18 years old. So anyway, there's a long history of behavioral risk factor epidemiology with kids all the way through adulthood and into MI and death due to cardiovascular disease. But this program pulled together a number of different investigators that did research in different areas of the school. And so there's a line of research with classroom curriculum. There's a line of research working in school food service. Back then, most schools would cook their own food. So they'd have, foods delivered, and they'd have recipes, and they would cook large lunches. So that part has changed quite a bit. Now they buy packaged foods for the most part. And so less emphasis there. In that realm, you want to try and get them to choose the healthier foods, but usually they're on a budget, so they don't. Not as much as you'd like them to do. And then there's a separate strand of physical activity research, and there's a separate strand of family-based research. And so 4 different components. And the original idea was, can we pull together those 4 components and try and implement them all at the same time? So that's what was happening in the pilot study. But just wanted to let you know, we've done a lot of work with NHLB. We've done a lot of projects. So this is the timeline for all the grants that I've been part of with Catch on it. And so it's been on and off in my career for some time. And actually, Texas, myself and our dean, Deanna Helsher, we've been working together on this since the very beginning. It got involved in dissemination of Catch. It was a four-site large randomized controlled trial. And this site, partly because I was interested in trying to apply some diffusion of innovation principles. Anyway, just to say, there's a long history. You can see the different programs and when they came online. And with Catch Global Foundation, there is a number of different investors, MD Anderson in particular. So we think Catch Global and UT as a strong partnership. So basically, a lot of those projects, all the materials from Catch have intellectual property assigned to them. And so they're in our Houston-based intellectual property office. They're licensed to Catch to distribute them. And then Catch collects money in different ways from different systems of cash reimbursement for training and materials too. And UT gets royalties. Then a little tiny trickle of royalties comes back to me. So enough sometimes to put on pilot studies. So I usually have about $50,000 in the catch royalty account that I can tap into for program improvements and for new program ideas and such. And that's kind of an important message too, to use the royalty streams to fund new developments, because where do you get the new money to do things which aren't in the budget originally? MD Anderson, by the way, I have to give a shout out to them. They gave Catch Global Foundation right after we started. We started in April, 14 years ago. And then in the following year, we got $4 million from MD Anderson. And that's because their population health director, and because cancer hospital systems, at least the coordinated or the big ones, which are in universities, the identified cancer treatment, they have something called community benefit that they have to do. So they have money set aside for community benefit, and they decided to use Catch for their community benefit in East Houston. So they gave us $4 million to start the center, and without that, we'd be nowhere. So I have to say, MD Anderson and Ernie Hawk are just fantastic people. Now, last week I emailed Ernie and said, "You got any more money? I do this every year or two." And he's like, "Not now, Steve, but you got to ask to get." Here's just a schematic of the different ways we interact with school systems. So the classroom teachers, we train them. There's before and after school groups that could be teachers. It could be an outside group like the YMCA or the Jewish community centers. We work with nutrition and food service. PE is one of our strongest elements, and it's the easiest to implement, and it gets the strongest results too. And so we do a lot of professional development with PE teachers. In fact, we probably trained half of the PE teachers in the state of Texas at one point or another in how to use this. There's also the middle school advisory period, and then family education too. So these compose many of those different strands I was telling you about that came together. We work with nursing and counseling too, not as much as we do with these 6 elements that are in the big print. But anyway, that's the way we're set up. Catch Global Foundation, one of the big things we do with that $4 million is transcribe everything which was in paper and in binders in school learning libraries. It became very expensive to print a copy of these materials. They're thick binders that, if I have to buy 50 of them for a school or several hundred for a school district, that's the bulk of the cost. So we took all that cost, got rid of it, and then digitized the whole thing. That cost about $300,000 of trial and error to get us to where we are with our website. And it's a turnkey system so that teachers can walk right up to their PC, go to the Catch website, click one of these tiles, and they're off and running. They have a universal password for school districts. That turned out to be a very convenient way. Everyone has the same password within the school district. Sometimes it's within the school if it's really big. But you can see we've grown quite a bit. So we found that these 4 different strands caused a little bit of confusion on who does what. And so we train schools that's what we mean by a coordination approach and a coordination kit. So we give them, a lot of schools are in 9-week cycles for their academic rotation. And so we now have the Catch rotation. So different people, the nurse, the school teachers at every grade level, the PE teachers. And so we encourage the schools themselves to have a committee just to implement Catch. And so the coordination Catch says, do these things in the first 9 weeks and do these things in the second 9 weeks and the third and the fourth. So we kind of made it routine. PE Journeys is the PE program. We've added social emotional learning. We found, lots of schools are saying, we have funding for social emotional learning, but we don't have it for PE. So can you guys make a blend of this? And it just makes sense anyway to get into the mental health issues that COVID created. So all of our programs have been through a redevelopment part where we tried to include many elements of social emotional learning. Catch Kids Club is the after school program. Sunbeatables was a program that MD Anderson contributed. So it's a kindergarten and early elementary school program to teach kids not to hate sunscreen so much, basically. My kids hate sunscreen, or they did when they were little. We developed a new program, Catch Healthy Smiles. And this is important, I think, for some investigators to know that you have to look at different funding streams, not just for dissemination, but also to get your research funded. So that was a whole new institute. Someone that I met at a conference has said, hey, National Institute of Dental Cranial Facial Research is going to lean towards behavioral stuff to prevent cavities rather than fill the cavities afterwards. And so we developed a relationship. I wrote a grant. I should say it's not me. It's a whole team of people that have done this work. So Srila Sharma in Houston is lead on the Catch Healthy Smiles. We're in the middle of an RCT project now. Then we took everything we knew about grades 3 through 5, and then we did grades 2 through kindergarten through 2nd grade, and then schools. This is feedback from the people who are using these programs. So, well, we want now, I should say, over the course of that time, schools started adding early childhood care to their campuses. And so that's particularly convenient for parents of students that have other children in the district or the kids of the staff themselves. It's a fantastic staff benefit to be able to bring your child to daycare on campus. So we created early childhood. And all of these different tiles that you see on here means that there is some level of research to make sure that the program was useful and had some positive effects and actually no negative effects. So this is what we do, is we build knowledge with different types of programs for different purposes. But in all of them, we try to build a skill building component. And that takes a little trial and error and a little bit of theory and best practices to say, well, what's the right skill building activity for a kindergartner to learn about their teeth? They can't even read. So, we go to those teachers, we confer with them, we have child development experts that we consult with. And so building some knowledge, like what is a cavity, skill building, well, let's brush our teeth, environmental support at family, school, or even larger units leads to a healthy decision. And we actually do consider that a change in behavior is our goal, but we'll take subcomponents of that, like knowledge, self-efficacy, intentions, and things of that nature too. But the goal is to change behavior. So once we get all that done, I followed Diffusion of Innovation by Carl Rogers. I learned that, and my first degree is in business, economics and marketing. And so I learned about diffusion of innovation in the late 70s. And then lo and behold, this comes along, the Catch Project. Well, I think I can use that to help me disseminate this in Texas, because there was dollars available in the diabetes prevention category, interestingly enough, and the cardiovascular disease. These are separate silo entities within the Department of State Health Services, and I was able to merge those two together and do a lot of training in Texas for many, many years, and we're still doing it. But I don't have time to explain all of these different things, just to say that this is the way we did it is basically the important part. So to look at the bottom left, diffusion, we find innovators and early adopters. We go talk to them, and they're more likely to grab onto this innovation of doing something about health at school, and then lead the charge within the district and on the campus too. You can see on the right-hand side in the bottom in the yellow about indicators of institutionalization. These are all things, in a cascade of importance, I think. And so getting a state to say they have approved of implementation of Catch relieves teachers of having to go through and convince people up the chain of command that they can actually adopt and implement a program. So once a state board of education stamps, yes, we agree with Catch, it's so much easier. And so you're on the preferred vendor list. And so last week, the state of Utah just approved Catch My Breath, the program that I'm going to talk about in a few slides. For those of you who aren't completely up to speed with implementation science, I used to call it diffusion of innovation. Now it's a variety of different things, but uses many of the elements of diffusion of innovation. As I train myself to understand more about the current vernacular with implementation science, this is a great website at Fogarty. And so I'm not going to talk much more about this. This page goes on and on and on with training opportunities and different systems and places you can go and websites. So if you have any interest at all in implementation science, I would go to this site and just start working your way through it. And by, before too long, you'll know a lot. And then a colleague of mine, Maria Fernandez, actually was able to get a vice president job at the Health Science Center level in Houston. So now there's an institute for implementation science. So I just put this up now, and in particular, this I took the screenshot this morning. There is a postdoc position open, and different places are eligible. Maria, the lead on this, we've been close colleagues for a long time. She really is interested in implementation science and is one of the leaders in national and is sat on the study section in NIH. So she can give a lot of good insight into grant proposals that are stronger or weaker to use the language of implementation science. It takes a little effort to learn it so that you avoid mistakes that reviewers are looking for that are fully up to speed with implementation science. And then this paper came along that helped me a lot. It's ERIC strategies have been around for a long time in drug education. So how do you implement drug education programs in schools? They're way ahead. They're 30 years ahead of the rest of us in this field. And so they've come up with 73 strategies, and these have been modified to work in schools very specifically and have been updated from the strategies which took place and were developed in the 70s and 80s. Now it's been completely up to date. Just to show you, of these 73, the ones in red are the ones that we're trying to either are trying or have worked in or do routinely in the CATCH program. And so this is a roadmap for ways to think about taking your programming, putting it into broad practice. I'm not going to go through this. I just want to let you know these are the categories of things that you can choose from. And that paper outlines all of this and provides the definitions. So now let's switch gears into one of the more recent products that we put together. And so vaping, I have to look at the time. Sorry. All right, I got a few more minutes. Vaping became an issue. You can see in the bottom in the purple, e-cigarette was introduced to the US in 2011. Monitoring the Future study added vaping in their measurement cycle in 2016. So now we have some information at a nationally representative level. Although the CDC has been measuring it since 2011. So you can see it, I don't have this on here, but it grew and grew and grew. And then the red bars are monitoring the future. No, I take that back. That's when the Surgeon General report came out. Something's wrong with my slides. Oh, sorry, I used too many colors. This red slide is when the Surgeon General report came out. Here in this slightly darker red is the vaping rate. So you can see it went up 17 to 18 and then peaked in 2019. It went down a little bit in 2020, down some more in 21, 22, 23, and now it's much lower in 24. So one could consider this a successful pattern. But the main point here is if you look all the way in 1976, actually that's the year I graduated from high school, and these numbers are current smoking rates, and so it went down, it stayed stable for a long time. I hate to say it, Steve got his PhD in 1992, and the smoking rate accelerated rapidly. Now, I'd like to think that's an ecologic fallacy, but it did happen. That's a little science joke. Anyway. So the Tobacco Master Settlement Agreement occurred in 1998. Then the funding got turned on in 2000. And you can see in broad results of teen smoking rate as to the variety of things that were funded by the tobacco settlement. As you may know, many states received millions of dollars as a result of this for many different purposes. Many states don't use it at all for prevention. They use it for treatment services for lung cancer or other cancer-related disease, or they put it in the general revenue and they just people forget that money even exists. Anyway, Surgeon General report came out in 2016, and I was invited to be on it. So in 2013, it took us 2 years to prepare that report. I became very interested in vaping. I sort of switched my lens from diet and physical activity and back to smoking, which I had done, previously in my dissertation and early work. But I started thinking, vaping is going to be so different than tobacco smoking. I knew this because I was a smoker in 1976, as was almost all the other people that I knew. And so I decided to write a separate program, and we decided to call it Catch My Breath. And it's solely about vaping and not so much about other tobacco substances. So there's Catch My Breath. So what is Catch My Breath? So it started with a middle school program, but it has too evolved with Catch Global Foundation to be grades 5 through 12. It's 4 core lessons at about 30 to 40 minutes apiece. And I said 4 core because school said we can't implement more lessons. We don't have time in the school day to do that, Steve. But Cochrane Review says you need about 14 lessons of classroom contact to see an effect. I'm like, well, what am I going to do? So we created a bunch of other lessons. We say it's core lessons plus if you can convince your science teacher to do some vaping, or your language arts teachers or the art teacher, or even in PE. I did the whole thing in PE orientation too. So you can implement this program in a variety of different things. And what you're hoping for is you find someone that gets excited and say, yeah, there's a vaping problem. I'm going to do something about it. You might be, again, the science teacher, the classroom curriculum, the 4th grade, whatever. So we give them a slide deck and scripts and discussion points. We have a parent toolkit. I will say this has not been particularly successful. I have not cracked the code on how to reach parents, although most others don't have anything better. I use the best practices. We got some results from this, but they weren't strong enough to say yes. However, I hear anecdotally parents, sometimes they email me that they appreciate at least learning about vaping. So here's the supplements are in STEM and humanities, PE. There's virtual field trips, which are completely online. The teacher will assign it as a homework assignment, and the kids just go and do it. And then they get a little certificate, and they give it to the teacher, and they can check the box in the grade book. We have self-paced modules for the kids. We've added cannabis vaping, and then fentanyl awareness because we're falling into the drug category with nicotine. And then there's a cross-reference with oral health and vaping because there are issues with vaping in the microbiome in the mouth and its relationship to dental caries, etc. So it was Delta Dental actually asked us to create additional oral health and vaping. And so again, this is a funding stream issue. So a lot of what we do is professional development. Duncan Van Dusen is the CEO of Catch Global Foundation. He lives here in Austin. He was one of my first students when we moved to Austin and began the master's program. And he volunteered to begin and steer Catch Global Foundation. And we decided that the program should be available for free. So the program itself, anyone can walk right up to it, grab it, use it. But we have videotape trainings because of COVID, because our trainers couldn't go all over the place. And then that morphed into train the trainers. And now we opened up the door with community drug funded, SAMHSA funded, designated funds for drug education are what's being used to pay these guys to do, school or district or sometimes even state level trainings on train the trainers. So I put the prices up on there just so you get a flavor for it. But I felt it important that it was free. And where we make money is on training, but training is free too. And so a lot of people walk up and grab it. But I think that's partly responsible to the success. Some of these school districts, they just want to get trained over and over again. There's a lot of turnover in schools. Here's the pilot test results. And again, I'm not going to go too deep into these, just to say that once we published this paper, once I published it, wrote it and published it, by the way, it took place right here in 4 school districts in Austin area. That was the key that unlocked state funds, because just like I was saying before, if you're an approved program at the state level, usually that means you need to have some evidence. So that allowed us to call ourselves evidence-based, that there was a good or a decent, a decent set of data underlying the program that says it works and does no harm, which is important in the drug education field. You don't want to teach them that vaping is tasty and what all the cool kids do. Today, we're all over the country. And so it's been massively successful. And it's partly because partly because I jumped in and wrote this curriculum. At the same time, I was working on, I wrote the chapter on health effects of vaping. So that's my epi hat. And then my health promotion hat. So let's do something. Let's write a program. And all the previous catch iterations, I think, got all of us with the know-how to disseminate things well. So we're in all 50 states, lots of coverage throughout the country. And then I pinged our data set, and we got 44 countries. I won't say they're using it regularly, but at least 44 countries have downloaded it, and I can see how frequently they're visiting. So some countries are using it a lot, and some aren't. But that's a success rate that I never really anticipated. And so all these factors that I've been talking about led up to very wide scale dissemination. And this is a big problem. Schools still don't know what to do. They catch a kid vaping, and what do you do with them? You can give them discipline, but do you discipline a kid that's addicted to an addictive substance? That doesn't seem fair. So you can refer them to someone for cessation. Well, there aren't any accepted and evidence-based teenage vaping or nicotine addiction programs. Although the Truth Initiative has one now that's I know the people at Truth, and they're about to publish a paper on their high school program, which does have cessation effects, which is really nice. So anyway, at that point, I got involved as an expert witness in the Juul cases that you may have heard have been settled throughout the country. So I created this logic model, which is one of the steps that I almost always get into to try and figure out what to do. So I made this, and you can look at this later, but on the left side, this is all the evidence from the Community Guide to Preventive Services and research about what works at the community level to prevent smoking with kids. And I took that and I explicated it across what I know and can build into community programs. Once I priced this out across the country, that's what the law firm said I should do. So I had to get involved in accounting and how do you properly adjust how much does media cost and how much do community boards cost. That was helpful with my business background. The result of, I won't say it's my work, but of multiple lawsuits, over $1 billion have been released in vaping prevention in the last year and a half. And it'll continue for a couple more years. And then that settlement money from Juul and from Altria, the parent company. Anyway, that was another interesting thing. I was helpful in releasing lots of money to do this at the national level. So just a couple more slides, and then I'll pass the baton. Whoops. So the way I operate with all these programs is understand the epidemiology of the problem. And so how many kids vape? How big of a public health problem is it? Understand the risk factors. Why are they vaping as best you can? These are separate types, surveillance at the top. Then we get into cross-sectional studies, sometimes case control studies, sometimes longitudinal studies. Then look for the risk factors and prioritize them, because you can't have the Cochrane recommended 14 30 to 50-minute sessions. It's just not going to happen. So you have to choose. And the way I do that is look at the odds ratio and judge the quality of the science and say, well, these are the things that the data says are the most important. It turns out that norms, child norms about how many kids use and how attractive it is the most important reason that the data say for smoking prevention. So I built that into the program in a heavy way. Then I prepare the logic model, develop the targets and strategies. I get input from teachers, students, parents. I follow a theory. I usually use social cognitive theory. It's hard to get every one of the elements, components of social cognitive theory, but I try my best to do it. And then so on. I'm going to let you guys read this at a later time. Here's a bit more advice. Here's where we're at now. We're looking for new investigators because I've got gray hair and I'm starting into phased retirement next year. I love this program. What I'm going to do, though, in retirement is to just switch over to Catch Global Foundation and help them with a few things. So I'll be hanging around for a while. But finding new investigators to further refine the oral health program, the smoking program. Now we're working in programs. You can see it there listed. Finding Focus is an academic achievement program. And Stephen, I see you've raised your hand. I think I'm out of time.
Well, this is really cool, and I'm politely saying, yeah, we should make sure we move
Yeah,
on, move forward. But
no worries.
thank you for this.
I think I came close to time. Let me stop sharing. There we go.
And I'm happy to share the slides with folks who were here too, so that everybody has those.
Sorry if I went over time, Kavita.
Thanks so much, Steve. And go ahead and introduce our second guest speaker. Dr. Kavita Radhakrishnan is the Associate Dean for Research at the UT Austin School of Nursing. Her research applies current and emerging technologies such as telemonitoring, connected sensors, and digital gaming to facilitate cardiovascular disease self-management. The long-term goal of her research is to develop affordable and scalable health interventions that enable aging in place. Dr. Radhakrishnan's research projects studying digital games for self-management in adults with cardiovascular diseases have been funded for over 6.8 million by the National Heart, Lung, and Blood Institute and the National Institute of Nursing Research at the National Institutes of Health. She has authored more than 60 articles, which have been cited in publications from more than 30 countries. She has also taught content related to health information systems, nursing research, and precision health science in undergraduate and graduate courses. Please welcome Dr. Kavita Radhakrishnan.
Thank you, Jay, for the introduction. I'm just going to jump in straight. I don't have a very long career, but I've been doing this for a few years, and I just want to talk about how we are adapting it for different communities of underserved populations, especially related to cardiovascular self-care. All right. So I was asked two questions. So I have it bold. What is the public health relevance of my work? It's basically to leverage commonly available digital tools for empowering cardiovascular self-care among underserved populations. The reason for that is, as I've seen, so my background is that I'm actually an electrical engineer, and then I moved to nursing, and then I started off in the ICU, moved to med-surg nursing, and then I was in home health. And across all my trajectory, I found that a lot of people get discharged, but they don't have frequent touch points with their providers. And so how do you help them take care of themselves at home? Because as a home health nurse, I believe that healthcare happens at home. So really, how do we give the tools? And a lot of people who have resources can find ways to take care of themselves, but how about the underserved populations? That's pretty much the gist of this work. I would like to acknowledge my research team, my partner in crime, Christine Julian, who was at UT and now is at Virginia Tech, and a game developer, a psychologist, and of course, cultural faculty from cultural communities who have helped shape this research, and my staff. So first of all, there is definitely a need for self-management and self-care, but the need for digital health tools to help empower that self-care. So there is a lot of patient confidence in terms of accessing the information, but not really the content of the information. Like, especially in this day and age with fake news and all kinds of information available, how do they really know what is the right thing to do to take better care of themselves? So I believe, so our team as such, we believe in digital citizenship. So there is a lot of saying that underserved population, you have people from low socioeconomic groups, well, they don't have access to cell phone. And that, I think, is a wrong way of looking at things, because a lot of them do have cell phones. There are a lot of cheap, low-end smartphones that people have. And to completely dismiss technology interventions as not needed for a section of population, I think is actually not equitable. So our group kind of argues that we would like to move the needle to, do the digital citizenship where people have more say and know how to use digital tools for, better care of themselves. So more engagement and more say. And to kind of exemplar that we hit upon this idea of digital games. So the thing is, digital games are something that's not threatening when it comes to healthcare information. It's accessible, it's fun, it's entertaining. So it's kind of like sneaking in your health information and health behaviors through the medium of digital games. The goal is provide easy to use information, rewarding healthy behaviors. And the idea is by doing that, you form healthy habits and eventually they get empowered. So the goal is to move the needle towards greater inclusion in health promotion. And again, the idea is having the onus somewhere midway, not just with the healthcare provider, not completely with the patient, but somewhere midway. So when it comes to this kind of research, we use a lot of community-based participatory research. We started off with heart failure patients and and older adults with heart failure patients. So that's really the genesis of this kind of research. And we started off with focus groups, interviews with actual heart failure patients as to what exactly do they like to see in a medium such as that. And then we kind of used that. So the population was older adults with heart failure, and then just adults with heart failure. And then we moved on to Native American tribe group with hypertension, and then Spanish-speaking people with heart failure, and then Spanish-speaking people, Hispanic population with hypertension. So there have been a lot of communities that we've been involving, and we have a template by which it's kind of getting easier and easier for us to work with communities to adapt our interventions. This so-called inaccessible interventions, but making it more accessible to communities. So, for example, in the Native American tribe group, we formed a community partnership committee, and members of the community partnership committee were elders from the tribe, adults with hypertension, the cardiac clinic staff who are part of the community, and clinicians. So it's a well-rounded stakeholder group that kind of looks at our tools and provides us feedback on how to adapt it to different groups. So some of the game design elements that we use, many of you are already familiar with, is points, badges, kind of recognition, leaderboards to, for the competitive streak people, and of course, incentives, like what is in it in you to play this game. So these are some of the general game design elements that we use to develop this. So this is really our product. It's I still have to come up with a better name, but really this kind of captures it. It's sensor control digital game. And our first game that we developed was this Heart Health Mountain. The idea is that the first game that we developed was use the casino slot kind of idea where participants play the game and then they improve their knowledge. But they can only continue to play the game if they also answer questions correctly and win points to play in the casino slot game. So kind of like this feed forward, feed backward kind of loop. But a very valid question that was asked is like, well, that just improves knowledge and it really doesn't do anything with their behaviors. And that's where we came about this idea of the sensor control digital game, where we partner with the engineering school. So the idea is they can only progress in the game if they do their behaviors, and the sensors track their behaviors. So using the data from activity tracker and weighing scale, and this is just an example of smart scale, smart sensors, but in this day and age with a lot of sensor devices around, it can be used to track a lot of behaviors. And then, so the idea is because their behaviors are tracked, they earn steps on the mountain, which they use to climb the mountain, and there is a big celebration when they hit the end of the mountain. And then each of the step is relates to some aspect of health behavior or health knowledge improvement. For example, a quiz question, behavior snippet. And the kind of information we provide is not pathophysiology information about heart failure, but more like tips and tricks. Like, for example, well, if you do gardening, that's a good thing to do as exercise. It can count it. Or maybe you can go to walk with your friends. Or if you're feeling particularly tired today, what are some of the things you can do? So just more pragmatic tips on how to take care of themselves, the cardiovascular disease in the day-to-day life. And then there are these contextually relevant messages. So they get these alerts, they get these messages that you can still do it. And we try to make it as encouraging as possible, that you've done better, but you can do more. So, anything related to the behaviors, and we use all features of the game to motivate those behaviors. So the idea of this game is, like I said, improve self-care. It's a medium by which they can participate in reality-based decision-making scenarios. For example, diet is also a really important part of cardiovascular self-care, especially related to sodium or low salt in diet. And this is a place where they can practice these behaviors safely, make mistakes, and then use these behaviors in real life. So the idea is to build skills, because they get these repeated attempts to build behavior, and they can safely build those skills. We use behavior change. We use quite a lot of behavior frameworks. A popular one that we use is the FOG behavior model, which is basically behavior happens when you have the right motivation, the right ability, and the right prompt. And then we also use behavior change techniques, kind of taxonomy, to kind of adapt our some of a game feature. In the interest of time, I'm kind of going fast, but I can answer the questions later. So I just want to provide an example. For example, in our older study, there was an issue with the game. Like, for example, some of the participants found it too easy, and they found a way, is there a way to increase the difficulty of the game? And so we brought in the kind of the behavior change framework, and then we changed the game feature. And one example was this long-term behavior quest, kind of the Duolingo idea. Like, it kind of builds on that. You have your daily task, but you also have your long-term task. So that kind of motivates you to stick to the behaviors. So these are some of our pilot study, like Dr. Kelder mentioned, these kind of studies kind of help us get the big, larger funding. And so we found some really good results in the game playing group. So we have two groups. The intervention group is the one that gets the sensors and the game. And the control group is also kind of an intervention group, because they all get the sensors. Like, every one of them get the sensor devices, the trackers, and the weighing scale, except the game playing group gets the game. The another thing that we do in terms of equity is we do not take our devices back. We kind of leave it to them, because it makes no sense to kind of build them to work on a behavior and then wean them back and take the devices back. So all our studies, we just let them keep the devices. Also, we were fortunate to have funding where for those, the thing is, 95% of our population, 90 to 95% of our population end up having smartphones. But for the ones who don't, we provide smartphones. So that way we try to build access to these kind of devices. So as you can see, there was nearly like a huge difference, 12 weeks for the weight monitoring behavior between the game group and the sensor group. And then in the step counts too, we could see like this difference between the treatment group, which is the game group, and the control group. And also we found like the game group, because they had this context that they had to engage in multiple behaviors at the same time, we could see a high correlation with multiple behaviors in the game group versus the sensor group. So these were some preliminary findings that helped us get further larger funding. And then just an example of participant feedback, where participants were disappointed that it ended so soon, and they found it really motivational, the game, to pay attention to their heart failure regimen. Some of them thought it was silly, but they still thought that they still found it really motivational to walk. So currently, those kind of findings helped us get some large grants. So we have two R01s and then one chipper that's internal pilot funded grant. So we are working with heart failure patients in 20 United States states with the highest disparities in heart failure. We use something called a decentralized trial, so which means we are based in Austin, but we conduct everything remotely. We ship them the devices, which is why it helps us that even though we are able to recruit people from 20 states, we can still conduct the research. And COVID is and I shouldn't use the word thank, but COVID really necessitated us to go remote. And so now we are just leveraging the remote technology to reach people from all over. And what we found is like we reach people who are 100 miles from the closest city. So whereas people would not, usually participants tend to be around cities where they have these large academic centers. And so they have easy access to these trials. But because of our decentralized trials, now we have access to people who are from really remote towns, like I said, 100 miles from the closest city, and they're able to participate in our trials. And then another trial we have is with a Native American tribe with high incidence of hypertension. And then lastly, we have trials with Hispanic groups, both Spanish speaking and English speaking. So kind of going to talk about how we are adapting it to different folks. So initially we just had like plain vanilla, not a lot of choice, but now we do, I'm just looking at the time. Okay. Whoops. So I need to speed up. All right. So we need to, they can choose their age, because the older adults in our studies didn't like looking old in our avatars. So we had like older looking avatars, but now they can change, select the age and skin color. The avatar changes in response to their behaviors. So and all of this is like engineering and algorithms in the back. So they can actually see the avatar reflecting their engagement and behavior. So these are some of the motivations that we use, and also climbing the mountain. We use a lot of culturally tailored education. We use it that's already available, and then we adapt it, and then we add some more. But a lot of the times we do not have to reinvent the wheel. There's already information available. And then this is in Spanish. So, again, we use culturally tailored information, food items that's relevant to their culture, and then education on how to read nutrition labels. And the thing is, we have a very small real estate in game-based medium, and that is actually a good thing because we're able to provide information in bite-sized chunks. These are some more culturally adapted information. We also provide, besides linguistic tailoring to language, we also provide literacy-based tailoring. So we realize some of the Spanish-speaking people can't read Spanish because they were only educated at like 3rd or 4th grade level. So we also have this audio to text kind of facility where they can still engage in the medium because it's being read out to them. We use a lot of cultural artifacts. So this was our initial game shop items, but then for depending on each culture, we use incentive items that's relevant to that culture. So that, again, all of this is to like motivation, recognizable landmarks in the game. So all of that, again, is to keep them in the game, sustain their game playing behaviors, because that means they're sustaining their healthy habits. So some of the key issues that I would benefit from further interdisciplinary collaboration is kind of like this vision for personalization at many levels. Some of the things that we are wanting to look at is, more storytelling in our games, cooperative gaming, social gaming. Right now, it's kind of based on this individual gaming, but how do we get this to be more cooperative? And so that is something we would like. Generative AI chatbots for tailoring, say if they have some kind of information, any question, then the game medium can be a way to address that. We would love to like match game mechanisms, even within the subcultural attributes and trends. So anyway, so I kind of wanted to just wrap it up. Like, we have a lot of ways to grow. It's really exciting in this day and age to grow, but we are proud of the efforts we have made to address some of the inequities, what we call the digital intervention generated inequities, and we're trying to address that using our medium. So making technology that is a convenient aid for behavior change with mindful, culturally tailored programming to improve health outcomes for all. Thank you.
All right. Are there any questions? I'll circulate the slide decks to all the attendees after we're done here.
There is a question. Well, there isn't a question about pairs yet. No, that is going to be our next step, because we would, the other thing that we would want to grow is like, how do we kind of merge this? And I know in this day and age, we have this FHIR, HL7 based API game apps that can help us integrate with EHR systems. So that is definitely our next step, is like, how do we inform provider practice, kind of provide a prescription behavior. The goal is to help providers provide a prescription behavior, and how we can use our medium to, that can be a prescription. So patients can follow that. So yeah, that is definitely a place to go. And payers, yes, that is another place to go. But, I just need more like staff and manpower to be able to run in all those kind of directions. So yeah, I mean, great ideas, and that's definitely something.
Yeah, agreed. It is a good idea. We were able to get some DSRIP funding in Houston, the Medicaid waiver funding. So it's kind of related, and some of that's still occurring. We went, a group in Houston, my colleague Shrila Sharma went in the direction of prenatal training for obesity and nutrition and physical activity. So she did a program and evaluation. It's still going on now. So that's our interaction with the medical community, to do it when mom is pregnant, and to try and work with her and family to pre-think all these things. But love the program you created, Kavita. It's seems very valuable. I guess one quick question is there any what are the speed bumps along the way of trying to digitally contact and maintain contact with people? COVID sort of threw us off our game too, in trying to talk to parents. Maybe we tried to talk to them too much, so they sort of tuned us out.
No, there are digital bumps, because we are constantly struggling with just the updates, and we used Withings, which was really good, but now that company decided that they don't want to support low-cost devices anymore, and they moved on to like higher-end devices. And so this for us, the biggest digital bump is keeping up with updates and keeping up with technology obsolescence. And then and when you have a 5-year grant, a lot happens in 5 years when it comes to technology. So having to just keep up with that has been a challenge. And then yes, we and same thing, right? Like, even at the participant side, like phone models change, and then some models are like outdated. So we really make a lot of effort for our programs to be, across iOS, Android, the lowest versions of Android that's still in circulation, things like that. But sometimes that is a problem. iOS definitely works better when it comes to data capture as compared to Android. So we struggle there, but I have a great staff who are really vested in this, and who work with participants across, to keep them going and working through technology bumps.
Yeah. Well, someday I'd like to meet and compare notes in that area. I know I don't do so much of what you're doing, but in Houston, there's a whole group that does that kind of work. You may know them. I've known Tom Baranowski for a long time.
Yes.
So you probably know the same people he does.
Yes, exactly. Same people. Yeah.
Well, thank you very much, guys. Appreciate it. Anything else to add, Jay or Stephen?
No, thank you. I'm just thinking about was just reading about the collaboration between DreamWorks and Arizona State, and it's like, how could we get like to create like, you know, interventions that are as sophisticated as,
Sure.
I mean, I noticed the comment from what, I forget how you said it. So they described it as, I forget what word you used that was funny, but it was it's silly, maybe is what you said.
Yes.
It's like, how do we catch up to entertainment industry and
True.
really, you know, use those, you know, because it's like, it's so encouraging that your data are both of you are in different way, you know, like your data are so encouraging.
Yeah, Arizona does fantastic work.
Yeah, it's really cool. Thank you.
Thanks for joining us, everybody. All right. We will be in touch with news about our next seminar series coming up in the spring. Hope everybody has a great holiday.
Okay,
Thanks.
thanks for having me.
Thank you
Bye.
so much.
Thank you.
Bye.